presentation, I'm sure we'll have more people. So let's begin. Very good afternoon, everyone. I'm Pranita, working as Director Research and Program at International Center for Research on Women, ICRW, Asia. On behalf of the Family Planning, Monitoring, Learning and Evaluation, FPMLE Consortium, I'm really pleased to welcome you all to our 5th webinar on potential of engaging private sector in achieving universal coverage in family planning. Thank you all for joining us today to learn and discuss about the private sector, current landscape, market share, and future potential in family planning domain. After meeting the revised goal for FP 2020, the family planning program in India aims to achieve universal health coverage for FP services by 2030. Realizing this goal requires both logistical and financial resources to meet the needs for contraceptives, which places the current FP program in India at a crossroad. This is a good time to review the scope and opportunities in the highly fragmented FP private sector market in India. We hope to make this webinar an interactive one and welcome questions and comments from all the participants as we progress. That's going to be very important. Before I introduce our two esteemed panelists, I would like to share briefly about the FPMLE Consortium, which was constituted 8 years ago with a goal to provide grounded evidence on efforts to improve family planning in India, with particular focus on Bihar and Uttar Pradesh. The consortium is led by Population Council and brings together technical support units led by CARE, India Solutions for Sustainable Development in Bihar, and the India Health Action Trust, IHAT, in Uttar Pradesh. Apart from them, ICRW, the Center on Gender Equity and Health, US San Diego, they're also part of this consortium to collectively support the family planning program with data-driven evidence. Today's session will focus on availability, affordability, inequities, challenges and opportunities, and way forward for role of private sector in family planning programming, particularly again in the context of Bihar and Uttar Pradesh. Our speaker today is Dr. Arupendra Majumdar, Senior Program Officer, Reproductive Health Division of Population Council, New Delhi. He's an anthropologist with an experience of over 22 years in population-based health research. Currently, he is leading the technical analysis of BMGF-supported monitoring and evaluation study on family planning in Bihar and Uttar Pradesh. He has worked on the Council's lead initiative titled Research and Analysis for Scientific Transformation and Advancement, RASTA, and Contraceptive Use Dynamics under the Evidence Project funded by USAID. He is an expert on impact evaluation in the field of sexual and reproductive health and has published a number of research articles in different scientific journals of national and international reputes and has presented his work at various conferences and platforms. His publication history indicates a diverse research interest with a focus on biosocial study of health at population level, maternal child health, and family planning. With us, our discussant is Dr. Bulbul Sood, a well-known figure. Dr. Sood is currently working as an independent senior strategic advisor for CHAI, PSI India, Ferring Pharmaceutical. She has been the former country director, Japaigo India, SEDPA India, and former professor of community medicine, Lady Hardinge Medical College, Delhi. Her areas of expertise include RMNCH plus A, NCD, women's cancer, international health. She has authored more than 40 publications in national and international journals, including chapters in books and contributed to development of several national guidelines. She has been an eminent figure in revitalizing postpartum family planning and introduction of postpartum IUCD in India, quality improvement in antenatal, intrapartum, and immediate postnatal postpartum care in both public and private sector, comprehensive primary health care through AVHW health centers, and working with INC and GOI to strengthen the nursing and midwifery cadre in India. Real great efforts and work Dr. Sood has done throughout. In the next 50 minutes, we will have Dr. Majumdar present for 20 minutes, and then followed by Dr. Sood sharing her views on the presentation and also the topic. Dr. Sood, you will have 10 to 12 minutes, and then we'll have 20 minutes for question and answer. We look forward to this interesting session. And once again, I request everyone being part of this webinar to please keep sharing your questions on the chat question answer window. You can also share your reflection, and we'll take all of those after the speakers have shared their views. With that, I'll hand over to Dr. Arvind.
Thank you. Thank you, Pranita, for introducing us so nicely. And I must express my thanks to all the participants of this seminar. And also, I may also thank the FPMLE consortium to give us the opportunity to share our research with the world. So, and at this point, I also want to acknowledge a few people like Dr. Abhishek Kumar and Ashita Mujal, who helped me to put together this presentation. And of course, our FPMLE team and all the consortium members. And whatever I'm sharing is our common sharing and like to share with the others. So with this, I'm beginning. This is my, just a minute. This is my first slide. So here, this is very well-known fact. The total fertility rate in India has kind of gone down in the last 30 years. And the decline is more rapidly in the rural area in the last 15 years. Much of this decline is contributed because of the increase in the modern contraception in both urban and rural area. But we can also see in the rural area, the contraception use prevalence is actually increased steadily. In urban area, it's not that much so. And the question is, the users are increasing in terms of proportion and numbers, where they are obtaining their methods from. And this is the result. We can see people are obtaining methods from private sector as well as public sector as well as private sector, more so from the public sector. And when we are talking about private sector, here we mean the commercial sector, that is the profit-making sector. But we also have another sector, which is non-profit making, that is also a private sector, non-governmental, that is our NGOs. So that contribution is quite minimum, but it's mostly public and private. And now we see which method people are obtaining from which sector. So as we know, India's market of family planning products and services are actually really dominated by the female sterilization. And we can see that people are mostly obtaining it from the public sector, not from the private. But when we talk about the non-clinical methods like condoms and pills, people are actually obtaining from the private sector. Although in the last 2 rounds of the NFHS, that shows there's kind of increase in public, not so much for the private. But it also, we also need to remember that we are talking about proportions. When we will translate into the numbers, it will actually, the market volume will actually grow for both private and public, because the base population is also growing. So now here we have some segmentation analysis. So which population segments are obtaining the methods from which sector? So you can see in the rural India, the private sector is actually increasing in a very slow but steady rate, but in urban India, it is more and more stable. And if when we talk about what kind of socioeconomic strata people they are obtaining from the WIS method, it is really encouraging to see those even from the weaker socioeconomic strata people are nowadays obtaining the methods from private sector. And as we can see in the poorest people, people belong to the poorest households or having low education level, they are also obtaining in a quite a number, they are obtaining from the private sector. Now, this is for a change from the NFHS data to local data like the M2WRA survey conducted by the TSUs of Bihar and Uttar Pradesh. That data shows so those people who obtained the clinical methods, they don't come to the private sector, as clinical method includes the sterilization and IUCDs. But the non-clinical method, they are, of course, people are obtaining those methods from the private sector more. And for the clinical methods, we can see a clear pattern of kind of income inequality. So like those families or those individuals belongs to the higher socioeconomic or higher wealth quintile or wealth tertile, they are obtaining the clinical methods from the private sector, but not that much stark difference we can see for the non-clinical methods. So at this point, we see what are the challenges for the private sector market, private sector market for providing the family planning services and products in India. As I mentioned just in the last slide, so that the income inequality is one of the challenge. So we can see that in an ideal situation, if this is like a Lorentz curves, and you can see the diagonal lines, those are the line of equality. So for example, for the public sector, we can see the Lorentz curve actually overlaps with the line of equality. It shows there is equity in this in terms of wealth and the method used. But those obtained from the private sector, we can see the Lorentz curve is very farther away from the line of equality. And it is the red one. This is actually represented what happened during NFHS 1. So, over the time, that have been reduced and the curve shifted towards line of equality. But still, the bad news or news of concern is we still have the significant gap from the line of equality to the NFHS4 data and Lorentz curve of that. Then when we talk about the private sector, we mean quality. People expect quality services from the private sector. Are we getting, at least in terms of family planning? Probably not. When we measure the quality of care in terms of, say, for example, informed choice, that one of the global measurement for informed choice is method information index. What does it mean? That if somebody is obtaining a method at the time of acceptance of method, whether that person did an informed decision or not, whether their decision to choose a method was with proper information or not. And what we can see, compared to public sector, the private sector have lower odds for giving the informed choice for the clients. And another aspect of quality is like the infection prevention. So this is for a change. This is a study actually was conducted by the FPMLE consortium in Bihar and Uttar Pradesh in the public and private health facilities of Bihar and Uttar Pradesh. And we can see the private facilities, they have better equipped with the infection prevention readiness, but the providers in those facilities, in spite of having readiness, they didn't practice their most of the infection prevention practices. So even the simple things, even like the washing their hands with soap, or even the using the gloves in the both hands, those simple things are not practiced, and that could can potentially be dangerous to the clients. So another aspect of another challenge for the private sector is they are up against the heavy subsidization of in the family planning market from the public sector. So here it's a different type of analysis. We can show that those people who obtain their method from a subsidized source that includes public as well as NGO sector, and we wanted to see who are the people are actually getting those methods from the subsidized sector. In rural area, the people from the very highest wealth quintile, they are like less than 10% they obtain from the subsidized. But in urban area, we can see kind of overuse of the subsidization. Even still today, 35% of the people from the richest quintile, they obtaining their methods from the subsidized sources. Now, there's a bigger question is whether the country should go with the program without subsidization or not, because that can pose a greater threat in terms of public health concerns. But we also need to do something so that there should be more targeted intervention instead of having a blanket approach. Then another aspect, and this is not only for just private, this is both for the private and public as well. This is about the provider preference. The global literature actually suggests that there are preferred preference exist. So providers not always follow the medical eligibility criteria for counseling clients. They sometimes say, for example, for newly married women or so the unmarried girls, there are some method restriction exist. So, for example, this is one of the study that again was conducted by the FPMLE consortium, is on as a qualitative study, and also we sent the mystery clients to the providers, and we found that those those are newly married or the unmarried girls. So people don't, I mean, only method they can only prescribe is the condoms, although they are medically eligible for other reversible modern methods. And when we asked, so why you are not following the medical eligibility criteria, or when they are allowed or they are medically okay to prescribe all different other kind of methods, so why you are not suggesting them? So this then, regardless whether the provider is from the public or from the private, they said, we live in a society and we need to follow the social norms and the sentiments of the people. So even if I just prescribe and there is any side effect, any mishap happens, some people will come and agitate against me, and then I will be in a very difficult situation. So I better follow the social norms rather than following the medical eligibility criteria. So enough about negativity. Now let's see where we can see where the positive stories exist. So what happened that, just a minute. What happened that, when we did a market development analysis of where is the potentiality of the market exist in India for the private sector to thrive. If somebody want to open a business, for open a private in a FP clinic, which are the localities where people, the business should start, or where they have a lesser chance to fail. So you can see this is this analysis says that most of the districts, Indian districts, the market is at the developing stage. So, but those red dots where the market is still in the very early stage. So that means they have less number of users, or less proportion of people are using, and more so they are using the subsidized sources instead of unsubsidized sources. And that is why the commercial sector, it is difficult to thrive. But over the time, from NFHS 4 to 5, we can see the red dots are diminishing. The more area are converting from from early stage to developing stage and developing to mature stage. And also in the NFHS4 data, we can show that, those metro cities and the second tier cities in the urban area, there are scopes to open to expand the business for the private sector, for the family planning market. So, and one of the reason is, as we mentioned earlier, the people actually obtain the methods, the non-clinical methods from the private sector. And over the time, we can see when FHS 4 to 5, the percentage of use of reversible modern method have been increased. So only now according to NFHS 5, only the pockets of like Andhra Pradesh and Telangana and some of the districts in Bihar, we have very high usage of sterilization or the clinical methods in India, where the other parts we can see there's an increase in the use of reversible method. And for if you think of that the private sector is mostly utilized by those who are the non-clinical methods users, so this is a good sign. And also, we must mention about some of the intervention studies have been done in throughout the years, like and they have addressed different issues that actually act as a barrier to the growth of the private sector, or it can also growth of the private sector as well as the family planning market. So like the campaigns like Goli Ki Hamjoli or Bindas Bowl, those intervention when it was actually was conducted mostly by apt associate, and that actually was consequenced in the use and the increase in the sale of condoms in North Indian cities. There was another example, not from India, it's from Paraguay, that we can say that there was a big policy change that had been done, and they addressed whether they want to continue their subsidy and how much they want to continue the subsidy, and that actually helped to growth in the private sector in Paraguay for the family planning. A review study and also showed how the voucher schemes actually were conducted by the global team of Population Council. It shows how the financial barrier can be reduced by using the voucher schemes for family planning services. I want to mention two more studies. It's not studies, two more programs, I should say. The Hausla Sajetari program in Uttar Pradesh, that actually helped to accredit and license to give the more private providers. So they are expanding the base of the service base for the population, and then that actually helped to give more choice to the clients. At the same time, the clinical outreach team by the then MSI International, they had the mobile vans, and they used to go to the geographically isolated or kind of inaccessible places on where the public sector facilities exist. So these last two are the kind of PPP models, so private public partnerships. So that mobile vans with the clinical outreach team used to go there, and if they just worked on the readiness of the facilities and providing services in those inaccessible areas. So what happened, that those people who are living around that facility, those actually are kind of located in a very remote places, they actually overcame the geographic barriers of getting their family planning services. So this is how the different examples where the barriers have been addressed. So I'm just quickly wrapping up to what are the way forward for the private sector and the family planning market in India. Number one, of course, if we can expand the provision of private sector, the clients will actually have a wider basket of choice, and there are also there's possibility of introducing more methods in the family planning basket of choice. using the private sector, and especially in the rural areas. That is actually will be very useful, because so far private sector is mostly concentrated in the urban area. Second would be a greater collaboration is necessary for the private providers to increase the human resource. So as like, for example, the Hostla Sajida is one of the examples when because if the trained providers, they are also providing the services through the private facilities. So that actually expanded the service base for the clients. And at the same time, it is very important to take care of the quality aspect, as we showed in one of the challenges for the private sector is the maintaining the quality. And here, even the private and public can work together. They can make some regulatory frameworks through accreditation, certification, and licensing, so that the people, when they're obtaining their methods from the private sector, they can ensure quality service. And last but not the least, to work with the professional organization like Foxy, and so that they can provide the supportive supervision through the family planning services for the better quality, and also to provide the services to all the people who need the family planning services. So that is the way we could achieve our universal health coverage in family planning program. So with this, I'm concluding. Thank you all of you for your kind patience. Over to Pranita.
Thank you, Arupin. Very comprehensive and interesting presentation, highlighting some of the important opportunities, but also challenges, and the need for addressing those challenges to really then only probably will be able to optimally leverage the vast private sector, that's private health sector that's available, and how best we can really engage for enhancing family planning services. Thank you a lot. Now I request Dr. Bulbul Sood to share her thoughts around this.
Thank you very much, Pranita. And I would first like to thank the organizers, the FPMLE consortium, for inviting me for this very, I would say, needed webinar. I think this one, as it says, potential of engaging private sector in achieving universal coverage in family planning is something which is very much needed. And thank you very much, Dr. Majumdar, for excellent analysis of the NFHS data from the beginning, from 1 to 5, looking at the trend. What are some of the challenges that you have identified aptly? What are some of the opportunities that we see now, and how we can then move forward? And of course, there are a lot of good news also. I see that India is moving towards what we were aiming to. As most of you would know, that already 21 states have achieved the replacement level of TFR of 2.1. We have 5 states, and I know UP Bihar is one of the big states which we have to now move forward. And I think that's why I feel it's very important at this stage to look at how we can have more people providing family planning services, which is there, which is the big private sector, which is there already in these 2 states, and Jharkhand, and of course also in some of the Northeast states, where Meghalaya and Mizoram. And what we can, then sort of look at, from both the policy level perspective as well as from the implementation level to, move forward and try to achieve the universal health coverage for family planning. So the TFR, you said rightly that, in fact, it was very interesting to see the MCPR in the urban areas and the rural areas, the divide is so less. in the urban area, you showed Dr. Mazumdar that it is 58 and in the rural is 55. So the MCPR is a good sign, you know. I think also you mentioned that, but in the urban area, there's only 2% point increase in the MCPR, and compared to what is when we are seeing in the rural areas. Rural areas, public sector, yes, you rightly said, pointed out that the public sector is a major provider of the family planning services across, and it's not just limited to these two states, but across other states also. But also we are seeing that, you know, when we look at some of the methods like oral pills and condom, the private sector is a major provider for those. And how we can, you know, use that to, you know, add other contraceptives or choices in their basket is very important. I would say that, you know, if you look at the data, you know, and what you have presented and some of the challenges, the issue of inequity is, you know, definitely there. And I think still when it comes to the private sector, the perception is mostly the rich or upper middle class who are using. But as the data shows that people are moving towards, you know, people also from the lower, you know, economic status, or women who were not so highly educated also moving. So then the India is becoming aspirational, and also I think it's very clearly is seen that you know, they are looking at quality care, and it is perceived that when it comes to quality care, it is the private sector where they go for. Of course, you did bring out the issue of some of the quality issue within the private sector also. I've seen that even from our experience of working in last 20 years with the various, you know, both public sector and private sector institutions, that when it comes to the public sector, you know, we have lot of inputs which goes on. You know, you would find that there are, you know, several, you know, in-service trainings which are given to the providers at all levels, whereas the private sectors somewhere is missing on. And that's why you find some of the issues around the informed choice that you mentioned about they may be having the infection prevention, you know, material, but when it comes to doing things, they are, you know, a little slow. So I think that is somewhere that definitely, as you have identified, is an important area that we have to look into. And you talked about the method information index, informed choice. I think one reason which I have seen, and again, this is in discussion with our colleagues from private sector, where, you know, we, in fact, when we were doing another program, which was to improve the quality of intrapartum and immediate postpartum care, you know, they don't have, in the public sector, you find you have the counselors, you have the ashas, you have the ANMs who are there to also talk about, you know, various methods, talk about, and increasingly, I would say in last 10, 12 years, much more information is being given. And NFHS data also shows that now the providers are much more willing to talk about the side effects also to the clients. In the public sector, it is happening. In the private sector, unfortunately, because there is no the other staff which is there. The counselors are missing, and sometimes even you find that, you know, the nurses are few. So and doctor doesn't have so much time to talk to the clients, and that's why you will find that, as you said, informed choice, and that's why the index which you talked about is slightly on the low side in the private sector. And I think that is something which is very important for all of us to look at, how we can work with the FOXI, with the Indian Medical Associations, other bodies like Indian Nursing Councils, to, you know, have more trainings for the staff in the, especially I would say the private sector, to update their skills, not just the knowledge, but I would say the skills also is very, very important. And that's why, as you mentioned, that we have to, if we have to involve the private sector in family planning services, it's important to invest in training and mentoring and monitoring, what kind of services they are rendering. So I think it is very important that we, and as a policymaker, they have to invest in the private sector also, looking at the quality issues that you talked about. Infection prevention, I know, has been a challenge for a long time, both in public sector and private sector. And I think it's always there that you may know about it, but practice is different. And I think that's, again, is very important for, all the colleagues that, have joined in, that ensure that, during your supportive supervision visits, make sure that whatever knowledge has been transferred to, various level of providers, that they are also, able to practice it and find what are the barriers to practicing. And then, try to, find a solution. And, I think infection prevention is something a weak area, not only in family planning, I've seen in most of the other areas also. Despite repeated trainings, availability of things, people tend to neglect it. I think the very important area that you brought out was the provider's bias, and about various methods, and also their preference. And I think that is something which is there, definitely. You have shown both in not only in UP Bihar, but if you look at, that's there all across the country, and in some other countries also. If you have to make sure that most of the providers, and if you ask the private sector especially why they don't talk about certain methods, I think they tend to think of my client, what will happen if something goes wrong. I would say their big worry is, and I still remember a long time back, there was one of very senior head of the department of one of the medical college, and I was talking to her about family planning, contraceptives. By end of our 10 minutes talk, she gave me all the, danger of giving X. If you do this, if you give pills, this will happen. If you do provide IUD, this will happen. Then I had to ask her, ma'am, but what do you give? You have to. And she was only thinking of the negative, side of, and all the methods. And I had to say, yes, all methods have, there is, a lot of good things, but there are side effects. But you have to tell the, clients about the side effects and give them a choice. So that informed choice is, we talk about it, but I think it needs to be imbibed into the psyche of the providers. The other area which is a big challenge is, again, talking to the married and the unmarried. And you would find studies after studies have shown that when it comes to unmarried, especially adolescent, the providers are not very confident, and they are not, also there is some resistance in their mind to talk to the young people. And that's why there is a barrier between the young people and the providers. And most of the young people then end up going to, people with half-baked knowledge. Or if they go, they are shunned, away, and are told to, forget about it, and, talk about abstinence and other things. So I think that's another area that we need to work in the private sector, especially more. And instead of talking about my patient, what will happen, if something goes wrong, if I give IUD, suppose infection happens, she does not conceive, or the other social cultural barriers which are there in the minds of the providers about, she has to prove the fertility. And so let her first have her first child, and then we'll talk about the family planning and other things. So I think some of the areas are very important. I don't think we have a simple solution to that, but we have to really, sort of sit with them, try to find out why, explain them in a way where, we are able to, clear their doubts, and then, bring out some of the important points that you talked about. I would say that there are opportunities, And I think you have very nicely brought out the opportunity that now people are shifting from, terminal methods to the reversible method, which is a good thing, So it's good to see even in the NFHS data, the IUCD rate has gone up. You find also the now injectables are coming up. We have more choices. Hopefully in another, couple of years, we should have, which already the program has started for implants and sub-Q. So we have more choices, and hopefully that will, move more women towards the, long-acting methods. But also we have to make sure that, the providers are well trained, providers are able to, skill to provide those services. And also, then a good follow-up is there for these clients, and ensure that, they, then can continue. But I also see that there is a need for, if you look at the unmet need in even the NFHS 5 data, there is a need for the permanent methods also. So I think we need to definitely have more people providing the sterilization services, not only in the public sector, but also in the private sector. And that's why important to roll in the private sector also. You talked about some of the program, Goli Ke Hamjoli and Hausla Sajidari. And I thought, I think it's important, and PSI India has done a wonderful work with Hausla Sajidari in UP. And when I was looking at some of the data, and one thing which comes out is why there are limited involvement of private sector in provision of family planning services. In other services, they are more involved, but in family planning services. And some of the things which come out is, one is, there used to be a very tedious and manual accreditation system, and that never attracted the private sector. Okay. Second is the validation of accreditation was limited earlier. You would find for 1 year. So, you go through that long process of accreditation, and by the time you get accredited, you find you have to revalidate, So private sector was not interested in going in for this. The private sector providers did not have access to government schemes also. And in fact, when in my discussion with Foxy members, that they always had this complaint that we didn't know what was happening, or we were not involved in it. Then, of course, there were multiple contradictory government orders and guidelines and things like that for family planning. And the biggest, I think, reason is, one is the trust deficit between the private sector and the public sector. And it is narrowing. And when I was looking at the Hausla Sajidari intervention, what was done, and I think that what I found, that they came up with an end-to-end paperless system, where in the government. So they were able to register the facilities as well as the providers. It was a digital transparent system, and then they worked to make sure that the system was scaled up, and, a kind of a maturity was attained. And in Hausla Sajidari in UP is seen as a best model for, that's why it's seen as a best model for strategic purchase of family planning services from the private sector. And I feel that these are some of the models which can be very quickly scaled up in other parts of the country, especially in Jharkhand and Bihar, where we still find the TFR is high. I was looking at some of the achievements of the Hausla Sajidari in UP, which was, again, as I said, was started implementation by PSI India in September of 2015. And it's wonderful to see that all the 75 districts are covered through this program, where the private sector providers are now enrolled. Almost more than 1,110 facilities have been accredited. Surgeons and panel are 870. And they have been able to unlock almost 126 crores with this money has been, and this money has been now So the private providers are very happy because they have been able to get so much funds. And also sterilizations and, they have been able to do almost 3.6 lakhs for sterilization, 6,000 NSVs, 1,38,000 OCPs have been given, again, 3 lakh or 4 lakh condoms, DMPA, ICD, 2 lakhs. So I think it is an opportunity where we can really learn from some of these experiences, especially with the private sector. And I think it's important that we scale it up, especially in the urban area, especially for the urban poor, urban middle class. I think a private sector would be a very good way to have a larger number of providers who can provide family planning services besides the ones which in the public sector, and then ensure that quick way of empaneling them, quick way of making sure that they are then reimbursed if developed. I think we would be able to achieve our goal of the universal health coverage for family planning. I'll stop here. Thank you very much.
Thank you, Dr. Sood. Very interesting points that you brought out, apart from like the opportunities, the way, the successes of Hosla Sajidari. You also talked about some of the challenges around the quality, informed choice, provider bias, also about the infection prevention, the gaps in the infection prevention. I just wanted to add that, definitely it's a clinical skill gap issue, but at times it's also gender issue where how providers see women, that also comes in that. But thank you for elaborating and sharing your thoughts on that. We have some questions from our audience, and I'll I'll ask Rupendra to respond. So there's one question where you have talked about the quality of services in the private sector, but then someone has asked, like, what is the practice of public facilities in terms of infection prevention? Do we have any experience from there?
Yes, as I showed in that slide, that we found that private sectors, at least when the data that we have from Uttar Pradesh, between private and public, yes, we have better readiness for infection prevention in private facilities, but the providers may not use. So I just mentioned about 2 examples, like just washing their hands before clinical procedure with soap. Simple steps are not being followed all the time. Say, for example, they have the autoclaves or boilers, but doing sterilizing their equipments properly with those equipments, on versus maybe pouring some hot water and going for the procedure. Maybe there are some instances, maybe they are very busy, or maybe more client load, or there are many consequences, but or circumstances. But overall, we saw, or the data shows that even if they had the readiness, the practice of the infection prevention procedure following the standard of protocol, that not been at par, or I will say that the providers of the public facilities, they're actually following the protocol more rigidly when they have the readiness than the private facilities.
Thank you, Arupen. So overall,
and actually,
yeah.
Remember, the study is actually done by both of us, and
yes.
You actually can reflect more on than me.
Yeah.
So yeah, thank you for that.
Pranita, can I just add to what
yes.
Dr. Mazumdar is saying? I think what I have seen that because of, and this has happened, changes more in last 10 years, because of the very supportive supervision and mentoring and monitoring, which is happening from the government sector and Lakshya and some of these other programs which have come. And that's why you find in the public sector,
Yes.
More and more people are looking at, not just saying that, okay, you have to have all the equipment and supplies, but also are they doing the practice? In the private sector, there's nobody to look at, So sometimes you may have everything, but then the
Yes.
human mind is such that you try to find a shortcut and, you
Yes.
avoid doing certain things. And I think that's why I think there was, it was mentioned also that the training is not just enough. Training and mentoring,
Yes.
monitoring is very important. Not monitoring like a policeman, but mentoring is very important to ensure
Yes.
that
Yes.
they are translated into practices.
Yes. Yeah.
Thank you. Thank you. No, it's very important. But like overall quality is lower, but we found that it's even more lower than in private than public. And Dr. Sood, as you said, there are reasons why we see, and also within those reasons, there are also evidence that shows us the way forward, how that can be addressed. There is another question which I'll request Dr. Sood to first take, and then Arupendra can come. So there's the question, we have been talking about private sector, but still it's more in urban area. What about rural areas? So even if private sector expands in rural areas, will the services be affordable for rural poor population? What is our thoughts? And maybe Dr. Sood, you can also think about how a system like Hostla Sajidari, where subsidized services or government pays for those services, can help address this issue.
Mazinda, you want to come first?
Okay, to me, it is what we, I mean, the question was asked in such a way. I think the person who made the question who's most talking about the clinical methods, but for the non-clinical methods, the gap is very minimum, as we can say. So even the like from the data that from Bihar and Uttar Pradesh, what we can see, the non-clinical methods, it doesn't matter whether a person belong to which health quintile or wealth quintile. So they are obtaining the methods more from the private sector. For the clinical methods, yes, there is a financial barrier. And there are ways, of course, as I mentioned, like voucher scheme that, and here I want to mention about one more study is about actually was part of DIMPA project, if you remember. So they, the APT Associate conducted this under the funding of BMGF. So in that study, there was two financial model have been used, although in the urban areas, of course, that is why the more private sector clinics were available. That is why it was done in permanent. But that those financial models can be used or can be kind of scaled up in the rural areas and to see whether that is making a sustainable change or not. So there are ways by which we can make the efforts of the private sector business is sustainable in the rural areas, but as because people still are, people using the methods or obtaining the methods from the public sector. So, but whether it is because of there is a lack of choice or lack of availability of the private sector in that area, or because of just because the financial, we don't know. But overall, as we can say, that now even people from the weaker, say lower socioeconomic strata, they are, if they are not, they are poorest wealth quintiles, they're also obtaining the methods from the private sector as well. So as Dr. Sood, you mentioned that the things are changing. The family planning, the market of family planning products and services are expanding. So we can expect that the market volume will increase, and that will is healthy for the family planning market, and especially for the private sector. So that is my take, and if we will like to hear from you if you have any kind of reflection.
So thank you. I think I just want to add on to what you said, that if you really look at the private sector, one private sector is not homogeneous, like when we talk about the private sector, one private sector is the OBGYN or the MBBS doctors. Then there's the whole ISMP, group which is there, Indian System of Medicine doctor. And in the rural areas, you find a large number of them are ISMPs, some trained and some not trained also there, Now, when we talk about the clinical services, if you look at, and if you look at the clinics, the private clinics, they are mostly, maximum they go down to is to the block level, you don't find that they are there, actually, because again, they have to look at the market, and since the market is not there, you would find that they are, again, India being such a diverse country, and I won't say it's just everywhere the same, because for example, you to go to Gujarat, the private sector is more at, than the public sector. But what we see that most of the people, the private sector, facilities are there at the tier 1, 2 cities, or then going down to some fair places, the block level maybe. Now, so the clinical services can be only provided with certain level of expertise. Now, one is that if you can find, and I think somebody needs to do this kind of a mapping to say where they are present, try and involve them through, having like Hostler Sazidari, where they feel a part of the system, and then they, and they are in panel easily, and then they are reimbursed quickly, If that happens, then you will find more and more private sector would be willing to join in also in this providing clinical services. The non-clinical services expansion, yes. I remember in the SIPSA days, even there was a program which was done through the ISMPs. They involved the ISMPs in giving the oral contraceptives and condoms, and we can look at, whether there are other things which can be, depending on, what the law permits, and what their association permits, that they can be given. So if they're already given some other injection, can they be given injectable after training? I'm just saying. So those are the things which will have to be looked at by the policymaker. But expanding the choices for contraceptives in the rural areas can be done. I see that there are opportunities.
Thank you. And it's also about increasing the choice of places, source from where they can access services.
Yeah, exactly.
Which is easier for them, convenient, and also affordable for them. So that's definitely important. There was one more question, which is on the tribal population and to what extent they have access to family planning services. And there is this thought that they are often being missed out, being a marginalized population, and they have to depend a lot on the traditional method. So both normative barriers, but it also has seems having a systemic barriers in terms of region. So I think time is now over, but I think we can always come back to our response to this question in the mail. But otherwise, it's been a really wonderful conversation, listening to the presentation, your reflection on these. Thank you, both of you. It's been really enriching. Thank you.
Thank you very much.
Thank you very much. Thanks a lot.
And thank you, everyone, for being with us, and hope to continue this conversation.
Thank you.